This is a PowerPoint presentation on the screening of Gestational Diabetes Mellitus, or GDM. What is GDM? Well, in its super simplest form, it's hyperglycemia in pregnancy. What's the normal physiology of pregnancy? Well, insulin sensitivity decreases, and this is caused by local and placental hormones: estrogen, progesterone, leptin, cortisol, placental lactogen, and placental growth hormone. And the effects of insulin on maternal tissue is reduced. This leaves higher levels of glucose in the blood that allows adequate glucose to be received by the fetus. Endogenous glucose production is also promoted, which breaks down fat stores, further increasing blood glucose levels and free fatty acids. The pancreas, aiming to maintain glucose homeostasis, experiences beta cell hyperplasia, which means that higher levels of insulin will be produced to combat the reduction in insulin sensitivity. How does the normal physiology change to pathophysiology? Well, pancreatic beta cells are the key to developing GDM, as they produce and secrete insulin. The trifecta of pathophysiology is reduced beta cell mass, reduced number of beta cells, and beta cell dysfunction. So beta cell dysfunction is thought to be a result of sustained and prolonged excessive insulin production as a response to extreme glucose intake. Beta cell dysfunction is also thought to be intensified by insulin resistance, and as cells throughout the body become resistant to insulin and hyperglycemia is persistent, beta cells are signaled to produce higher levels of insulin, which overburdens beta cells. This is described as glucotoxicity and begins a dangerous cycle of hyperglycemia, insulin resistance, and then further beta cell dysfunction. Glucotoxicity results in beta cell apoptosis, reducing the number of beta cells and putting again more stress on existing beta cells. In normal pregnancy, beta cells would undergo hyperplasia, but with impaired performance of existing beta cells, they're not able to do this as effectively, which results in reduced beta cell mass. Chronic insulin resistance exacerbates hyperglycemia. There's a failure in cell signaling, causing cells not to respond properly to insulin. This failure is caused by an increase in saturated fatty acids that interfere with insulin signaling and gum up the receptors, so insulin can't bind with them. It's estimated that insulin-stimulated glucose uptake is reduced by 54% in GDM when compared to pregnancies uncomplicated by GDM. In most cases, beta cell impairment and tissue insulin resistance already exists prior to pregnancy, but it's not reached the point of chronic hyperglycemia, leading to diabetes. But metabolic stress of pregnancy can exacerbate this and result in GDM. Organs other than the pancreas are affected by or contribute to GDM. These include the brain, adipose tissue, liver, muscle, and placenta. So, who do we screen for GDM? Well, NICE guidelines suggest that at the booking appointment, midwives pre-screen women to see if they're at risk of developing GDM. These risk factors are BMI above 30 kg per metre squared, previous macrosomic baby that weighs 4.5 kg or above, previous GDM in a different pregnancy, a first-degree relative with any sort of diabetes, or a family history with a high prevalence for diabetes, so that's BAME women. And if any of these risk factors are identified, then the midwife will offer screening bloods. At every other further appointment, regardless of risk factors, midwives should be using a dipstick to test pregnant women's urine for glycosuria. NICE recommends screening bloods for women that have glycosuria of 2+ or above on one occasion, or glycosuria of 1+ on 2 or more occasions. The lovely pandemic. It's drastically changed the way we screen for diabetes. Before the pandemic, NICE guidelines recommended using oral glucose tolerance tests at 24 to 28 weeks for those with risk factors. For women with previous GDM, they would offer a self-monitoring system and an oral glucose tolerance test as soon as possible, with an additional test at 24 to 28 weeks if the first was normal. This is still considered gold standard for screening and diagnosis by the World Health Organization. So, during the COVID-19 pandemic, the Royal College of Obstetricians and Gynecologists proposed a temporary screening pathway for women with risk factors. The amended pathway was intended for the peak of the pandemic only, with intent for trust to return to the NICE recommended screening pathway once the risk of transmission allows. This is because the oral glucose tolerance test requires long waiting times in large groups. The new Royal College of Gynecologists and Obstetricians guidelines recommended HbA1c and random plasma glucose to be done at booking, with a diagnosis of GDM if HbA1c is 41 to 47 millimole per mole or random plasma glucose of 9 to 11 millimole per litre. But if women have a HbA1c of above 48 millimole per mole or a random plasma glucose of more than 11 millimole per mole per litre, then they should be considered as having type 2 diabetes and cared for accordingly. And then at 28 weeks, women who remain high risk of GDM without a diagnosis should be offered a repeated HbA1c with a fasting plasma glucose or random plasma glucose if fasting can't be facilitated for some reason. Diagnosis of GDM should then be made if women either have a HbA1c of more than or equal to 39 per millimole per mole or a fasting plasma glucose of more than or equal to 5.6 millimole per litre or a random plasma glucose of more than or equal to 9 millimole per litre. Is this working? Well, Meek et al. 2020 looked at the performance of screening and diagnosis of GDM during the pandemic and found that it does identify women with hypoglycemia at the highest risk of adverse pregnancy outcomes, but Nashtagale et al. 2021 found that the RCOG pandemic recommendations actually have poor sensitivity compared to their oral glucose tolerance test, identifying that women with GDM are going undiagnosed. So the question now is, when will the pandemic be at a stage to reintroduce the oral glucose tolerance test, and how many women have been receiving substandard care? Women should also be screened for GDM if they have any symptoms associated, so nocturia, polydipsia, polyuria and fatigue, or on an ultrasound scan a diagnosis of large for gestational age fetus or polyhydramnios. All women should also be individually holistically assessed on an ongoing basis. HbA1c. What is it? It's a blood test, and it's referred to sometimes as glycated hemoglobin. HbA1c refers to glycated protein in erythrocytes. Glucose binds non-enzymatically to a residue in the B chain of the protein adult hemoglobin. And as erythrocytes are freely permeable to glucose, the test uses erythrocytes' 120-day lifespan to determine glycemic history of a pregnant woman. A random blood glucose is self-explanatory. It's a blood test that measures the glucose levels in the blood at the exact time of the blood test without knowledge of food or drink intake. And then a fasting blood glucose level is when the woman has been fasting for 12 hours or more. The gold standard oral glucose tolerance test. It measures blood glucose levels at 2 different times. The first is a fasted blood glucose levels, and women should be fasting for 12 hours previous. The woman will then be asked to drink a glucose drink. In TrustX, this is 113 ml of polycal made up to 250 ml with water. The woman will then wait for 2 hours and have her blood taken again, which is a 2-hour plasma glucose. To diagnose GDM, a fasting plasma glucose level of more than or equal to 5.6 millimole per litre or a 2-hour plasma glucose level of more than or equal to 7.8 millimole per litre. Midwives don't diagnose GDM, but it's important that we understand and know the figures surrounding diagnosis. What else are the midwives' roles and responsibilities throughout the screening and diagnosis process? Well, midwives need to recognise which women are in the at-risk category, and then counsel the women on what a diagnosis would mean for them, discussing diet control or the possible need for blood glucose lowering medication, for example, metformin or even possibly insulin. And then explaining to women that if gestational diabetes goes unmanaged and undetected, that there could be serious risk to both them and their baby. Also informing them that they may need additional interventions throughout antenatal period, labour and birth. Midwives should also ensure that women know they're in control throughout the whole process and every decision is theirs to make. The NMC code set out professional standards for midwives. So Professional Standard 3.3 can link to women with gestational diabetes, as it dictates midwives act in partnership with them, giving relevant information and support. 13.2 to make referrals to other practitioners when additional care is needed. This also fits well with gestational diabetes cares, as once a diagnosis is made by diabetic clinics, community midwives must ensure that referrals to relevant healthcare professionals are made. The code underpins all that we do in midwifery care, and more links can be made to the care of women with GDM. Multidisciplinary team involvement. The woman should be referred to the Joint Diabetes and Antenatal Clinic as soon as possible. So, antenatal clinic comprises of a diabetic specialist nurse, a midwife specialist, a dietitian, a sonographer, an endocrinologist, and an obstetrician. Here, the woman will receive additional care throughout their pregnancy, and the midwife will remain coordinator of care and ensure that the woman is able to access all of her appointments and understand fully what's happening to her. And these are the references.